Every 40 seconds, an American has a heart attack. That's not a statistic from a cardiology textbook. That's from the American Heart Association's 2023 report. One person every 40 seconds. But here is what that number doesn't tell you. Many people do not recognize early warning signs before a heart attack. They felt what they thought was stress, or tiredness, or acid reflux, or getting older. They ignored it, and their heart couldn't wait any longer. I am Dr. Henry. I have 15 years of clinical practice. I have sat across from patients in the days after cardiac events and heard the same sentence over and over. I thought it would go away. Today I'm going to show you the 5 warning signs your heart is sending you right now. Signs that most people dismiss, signs that your doctor may not have time to explain, and exactly what each one means biologically, so you can stop guessing and start acting. Subscribe to Be Well right now and hit the like button. It takes 5 seconds. Let's get into it. Let me tell you about Frank. Frank was 58 years old, a retired teacher, physically active. He walked 30 minutes every morning. He came to see me because he'd been feeling off. That was the word he used, off. He was tired in the afternoons, even after a full night of sleep. He'd noticed he was short of breath climbing stairs he'd climbed for 20 years without thinking about it. He had an occasional ache in his left shoulder that he blamed on sleeping wrong. And once a week, roughly, he had what he described as heartburn that felt strange. His GP had checked his cholesterol 18 months earlier. It was borderline. He was told to watch his diet. 6 weeks after he came to see me, Frank had a moderate myocardial infarction, a heart attack, that required 2 stents. He survived. He is doing well. But the 18 months before that, his heart was telling him, every single day, his story is not unusual. It is the rule. Here is what almost everyone believes. If your heart is in serious trouble, you will feel it. You'll feel chest pain, crushing pressure, arm pain. You'll know. That belief is dangerously wrong. The Hollywood heart attack, the man clutching his chest and falling to the floor, represents a small percentage of cardiac events. The majority present subtly. They mimic indigestion. They mimic fatigue. They mimic anxiety. They arrive slowly, over months, before anything acute happens. A 2019 study published in JAMA Internal Medicine found that a significant proportion of heart attacks were unrecognized at the time and discovered later, often without typical symptoms. They showed up on an ECG later, entirely unknown to the patient. Your heart does not send a memo. It sends signals, small ones, and if you don't know what to look for, you will miss them. To understand why these signs appear the way they do, you need to understand what is happening inside the coronary arteries. Your coronary arteries are the vessels that feed the heart muscle itself. They are roughly the diameter of a drinking straw. Over years, accelerated by inflammation, oxidized LDL, blood sugar dysregulation, and elevated blood pressure, plaque accumulates inside these walls. This is called atherosclerosis. The critical thing to understand is this: the plaque does not grow uniformly. It grows in pockets, and those pockets can narrow an artery by 40%, 50%, even 60%, with no symptoms at rest. You only feel the restriction when demand increases, climbing stairs, carrying groceries, dealing with stress. That effort-related symptom is the first warning. Most people blame it on age. Additionally, the inflammatory process around developing plaque triggers the nervous system, which is why cardiac events often feel like anxiety, indigestion, or musculoskeletal pain. The nerves serving the heart share pathways with the nerves serving the jaw, shoulder, back, and stomach. The signal gets misread. Now let's go through the 5 signs, one by one. The first sign is fatigue that does not match your activity level. This is not the fatigue of a hard week. This is fatigue that arrives without a clear cause, that rest does not fully repair. That is worse in the afternoon, and that has been gradually worsening over weeks or months. What is happening biologically? When your coronary arteries are narrowing, the heart muscle is receiving less oxygen than it needs to maintain optimal output. The heart compensates. It works harder. Sustained compensatory effort consumes more cellular energy. Mitochondrial output in cardiac cells decreases. The result is systemic fatigue. Your body is diverting resources toward keeping the heart functional, and everything else gets less. The clinical term for this early-stage fatigue pattern is cardiac fatigue syndrome. It is distinct from thyroid-related fatigue or sleep disorder fatigue in that it tends to worsen with light exertion and improve slightly with complete rest. What to ask yourself: is this fatigue new in the last 3 to 6 months? Does it seem disproportionate to what you've done? Is it getting gradually worse? If you answer yes to 2 of those 3, mention it at your next appointment, not as tiredness, as a pattern. The second sign is shortness of breath that arrives at effort levels that never used to cause it. Frank noticed this on stairs. Many patients notice it carrying groceries, walking from the car to a building, or getting dressed in the morning. They assume it is deconditioning. They assume they have simply become less fit. Sometimes that is true, but shortness of breath on mild exertion, especially when it's new, especially when it's progressive, is one of the clearest early signals of reduced cardiac output. When the heart is not pumping efficiently, the lungs begin to compensate. Fluid can shift into the pulmonary tissue, a condition called pulmonary congestion, which reduces the efficiency of gas exchange. You breathe harder to get the same amount of oxygen. The distinction that matters: effort-related dyspnea that resolves quickly when you stop is different from dyspnea at rest. If you're short of breath lying down, if you need to prop yourself up with pillows to sleep, that is a more advanced sign and warrants urgent evaluation. Effort-related dyspnea that's new and progressive is the earlier warning. Sign 3 is discomfort in locations that have nothing to do with your chest. The jaw ache you blame on grinding your teeth. The left shoulder that aches without injury. The pressure between the shoulder blades. These are classic referred pain patterns from cardiac ischemia, meaning they are pain signals originating in the heart, arriving somewhere else. This happens because of shared dermatomes, nerve distribution zones. The nerves feeding the heart exit the spinal cord at the same levels as the nerves feeding the jaw, neck, left shoulder, and upper back. When the cardiac nerves fire distress signals, the brain sometimes assigns that signal to the wrong location. This is more common in women than men, which is part of why women's cardiac events are more often missed. Women are statistically more likely to present with jaw pain, upper back pain, and nausea rather than classic chest pressure. Any unexplained recurring ache in the jaw, left shoulder, upper back, or inner left arm, without a clear musculoskeletal cause, that comes on with exertion or stress and fades at rest, deserves cardiac evaluation. Sign 4 is what feels like heartburn but doesn't respond to antacids. The heart sits directly behind the sternum. The esophagus runs beside it. When the heart muscle is ischemic, receiving insufficient blood, the pain can feel like a burning, squeezing, or pressure sensation in the center of the chest, directly mimicking acid reflux. The distinguishing features: cardiac chest discomfort tends to be triggered by exertion or emotional stress. It tends to last 2 to 20 minutes and then fade. It does not improve significantly with antacids or positional changes. It may radiate to the left arm or jaw. Acid reflux, by contrast, tends to worsen when lying flat, respond to antacids, and be associated with specific foods. In clinical practice, one of the most common misdiagnoses is refractory GERD in a patient who actually has unstable angina. If you've been told you have acid reflux but it's not responding to treatment, insist on a cardiac workup. The fifth sign is awareness of your own heartbeat. Most of the time, you don't feel your heart beating. When you do, when you feel it flutter, skip, pound, or race without explanation, that deserves attention. Occasional palpitations from caffeine or stress are common and usually benign. But palpitations that are new, persistent, that occur at rest, or that are accompanied by lightheadedness or near fainting are different. The most important arrhythmia to screen for is atrial fibrillation, AF. In AF, the upper chambers of the heart beat chaotically rather than in coordinated rhythm. AF increases stroke risk by 5-fold. It is estimated that 12 million Americans have AF, and approximately 30% of those are undiagnosed. AF often presents as a fluttering sensation in the chest, irregular pulse, fatigue, or mild breathlessness. It may come and go, paroxysmal AF, and disappear before a standard ECG can capture it. If you feel intermittent irregular heartbeat, ask your doctor about a 48-hour or 2-week cardiac monitor, not just a standard 12-lead ECG. Now that you know the signs, let's talk about what creates the conditions for cardiac disease to develop. Because removing these drivers is how you reduce risk. Driver 1. Chronic low-grade inflammation. This is now considered the primary engine of atherosclerosis, not cholesterol alone. Elevated high-sensitivity CRP, a marker of systemic inflammation, is a stronger predictor of cardiac events than LDL in many population studies. Sources of this chronic inflammation include processed seed oils, refined carbohydrates, sleep deprivation, and chronic stress. Driver 2. Elevated fasting insulin and blood sugar dysregulation. High blood glucose damages the endothelium, the inner lining of blood vessels, making it sticky and permeable to oxidized LDL. This accelerates plaque formation. You do not need to be diabetic for this process to occur. Prediabetes affects 88 million Americans, most undiagnosed. Driver 3. Elevated blood pressure. Sustained hypertension creates mechanical shear stress on arterial walls, accelerating endothelial damage and plaque vulnerability. The upper target for most adults under 65 is now 120/80, not the old 140/90. Many people in the gray zone of 125/135 systolic are accumulating damage without treatment. Driver 4. Sleep apnea. Obstructive sleep apnea causes repeated oxygen desaturation events during sleep, spiking sympathetic nervous system activity and blood pressure. It is profoundly underdiagnosed and doubles cardiac event risk. If you snore heavily, wake unrefreshed, or have been told you stop breathing in sleep, a sleep study is worth pursuing. Now let me give you the 3 tests that actually tell you what is happening inside your coronary arteries, not just your blood. Test 1. High sensitivity CRP. This measures systemic inflammation. Standard CRP testing misses low-level chronic inflammation. High sensitivity CRP does not. A level above 2 mBrl indicates elevated cardiac risk independent of cholesterol. This test costs under $30 and is available at most labs. Ask for it by name. High sensitivity CRP. Test 2. Coronary artery calcium score. This is a low-radiation CT scan that directly measures calcified plaque inside your coronary arteries. It is the most powerful predictor of future cardiac events in asymptomatic individuals. A score of 0 confers very low risk. A score above 100 significantly elevates it. A score above 400 is high risk and changes treatment decisions. This test is not routinely offered. You often need to ask for it or self-refer. It costs $100 to $200 and requires no contrast dye. Test 3. Fasting insulin level. Not fasting glucose, fasting insulin. Standard metabolic panels check blood glucose, but elevated insulin with normal glucose is the earliest metabolic warning sign. Elevated fasting insulin levels may indicate insulin resistance, an early metabolic change associated with increased cardiovascular risk. This test is inexpensive and routinely available. Most doctors do not order it routinely. Ask. If your doctor is not familiar with hsCRP or fasting insulin, print this out and bring it. These are not alternative medicine tests. They are mainstream laboratory markers with decades of peer-reviewed evidence behind them. Frank had 2 stents placed. He survived. But I want to tell you what happened in the 2 years after. We put him on an aggressive anti-inflammatory protocol. Not primarily statins. His LDL was not dramatically elevated. Anti-inflammatory. Removing processed seed oils, eliminating refined carbohydrate spikes, Mediterranean pattern eating, omega-3 supplementation at 2 grams of EPA and DHA daily, and structured stress management. We tested his hsCRP at baseline after the event. 6.2 mg/L, significantly elevated. At 6 months, 2.11 mg/L. At 18 months, 0.9 mg/L. Below the threshold for elevated risk. His coronary artery calcium score at the 2-year mark, not his original score but the rate of progression, had effectively stopped. 0 new calcification in 2 years. He still walks every morning. He's now 61. He tells me the 5 symptoms I just described to you. He had all 5. For over a year. He thought they were the price of getting older. They weren't. They were his heart trying to get his attention. Step 1. Take your blood pressure at home, at rest, 3 mornings in a row. Write down the numbers. If the average is above 130/80, book an appointment. Step 2. Notice your breath tomorrow. Walk up 1 flight of stairs and observe what happens. Is this different from 2 years ago? Document it. Step 3. Ask your GP for these 3 specific tests at your next appointment. High sensitivity CRP, fasting insulin, and a fasting lipid panel. Bring them in writing if necessary. Step 4. If you have unexplained fatigue or exertional shortness of breath, ask specifically about an echocardiogram, an ultrasound of your heart, not just an ECG. An ECG can be completely normal even with significant coronary disease. Step 5. Reduce highly processed and fried foods, which are associated with increased inflammation and cardiovascular risk, and focus on a balanced diet rich in whole, minimally processed foods. Step 6. If you snore heavily or wake feeling unrefreshed regardless of sleep duration, ask about a sleep study. Undiagnosed sleep apnea is one of the most powerful and most ignored cardiac risk factors. Step 7. If you feel anything unusual, flutter, pressure, breathlessness, jaw ache, and it comes on with effort and goes away with rest, go to an emergency room. Do not wait to see if it happens again. The interval between a warning event and an acute event can be days. Your heart has been working without a break since before you were born. It doesn't take days off. It doesn't ask for anything in return. All it asks is that when it sends you a signal, you listen. The system is not built to give you this level of detail. A 12-minute appointment does not have room for this conversation. That's why this channel exists. Write your age in the comments below. Tell me which of these 5 signs resonates. Because what I cover next is shaped by what I hear from you. If you haven't subscribed, do it now. Share this video with one person whose heart health you're worried about. It may be the most important thing you do today. I'll see you in the next video.